Bienvenidos a otro segmento de CRF News. Hoy les traemos una charla muy interesante, sobre todo para los que son amantes de la enfermedad estructural. El Dr. Mackensen de la Universidad de Wisconsin, que es a propósito un anestesiólogo, que es un dato muy interesante, dio una charla en el Structural Heart Disease Summit de este año, donde muestra la utilidad y la aplicación del eco transesofágico para la guía de la terapia percutánea mitral y tricuspidia. Esta charla es muy interesante porque no solamente habla de cuáles son las imágenes, las aplicaciones, la localización, etcétera, etcétera, pero trae unas imágenes espectaculares para los que son amantes de la enfermedad estructural, así sea en la parte diagnóstica o en la parte terapéutica. Yo espero que de verdad la disfruten porque tiene unos aspectos muy prácticos en cuanto al uso de la ecografía transesofágica en estos procedimientos que cada vez se están volviendo más comunes en nuestro campo. Ojalá que la disfruten.
Thank you very much for the invitation to speak at this panel. I'm going to try to use the next 10 minutes to give you a quick overview and a few highlights of how imaging has evolved from an echocardiography point of view using TE for these procedures in both mitral and tricuspid valves. I have no disclosure relevant for the talk. We've come a long way if you think of these valves in the past to open heart valve repairs on cardiopulmonary bypass to now minimal invasive surgeries or interventions no longer using the heart-lung machine such as the mitral clip on the right-hand side. But we've also come a long way with imaging modalities such as echo. And if you think about 10 years ago, we started doing some of the 3D imaging. Now the quality has gotten so good, and all of the different machines out there will allow in-depth 3D as well as biplane imaging, which is important. If you look at these two examples, just briefly on the left, the more mobile degenerative mitral regurg will be associated with a specimen like this one. We see actually cords both to anterior and posterior leaflet on the left-hand side, as opposed to a much more functional MR on the right-hand side. All strings are attached and under a lot of tension, not allowing the mitral valve to come up to a meaningful coaptation. Now, as we do these procedures, we always have to think about the transeptal puncture, and all I wanted to say based on this slide is use 3D as well as biplane imaging, because it's not just the point to get the interventionalist across the septum, it is where to get them across the septum and stay safe and stay within the means of what we're actually trying to accomplish. For instance, on the left side image, you see the mitral valve annulus. It gives you a lot of fiduciary comfort that you really are where you're wanting to come across the septum. The right-hand side is just the same data set displayed in different ways, and you can slice and dice it any way you want in order to be certain about sizing and length diameters. Next, there's a P1 prolapse here I wanted to bring to your attention, again using a comprehensive 3D as well as 2D assessment to set ourselves up for success. And that's critically important. The left lower image shows the view from the posterior medial commissure into the anterolateral commissure, really looking into the defect. And once you've understood the pathology, you can set up your mitral valve repair with a mitral clip much more meaningful way. This panel of 9 images shows on the left-hand side the baseline situation. In the middle, our first attempt with a rotated clip to accommodate for the commissural line, but maybe not rotated enough. And as you see on the next moving images, you'll see that there's still a commissural jet, which we wanted to avoid. So what it took is actually to move much more clockwise, if you will, so that the clip was orientated between 2 and 8 o'clock, which finally gave us, with a single clip, the desired result, as you see in the right-hand bottom, with the color now showing clearly no more commissural jet as opposed to the image just next to it. Again, clip orientation to respond to the accurate pathology is key, and it's on you as interventional proceduralists to demand your echocardiographer to get the best out of our equipment that we have. Also useful is an opportunity to look at the mitral valve from above and below. Unfortunately, this is not playing, but it may display right here that you see a strut cord that's important to avoid. Now it's playing. So you have an enface view on the left, aortic valve on top, and the ventricular view on the right-hand side, showing the anterior leaflet, again, still on top. Very useful to assess anatomy. We've summarized a lot of the echocardiographic imaging and guidance for the edge-to-edge repair of the mitral valve in this paper earlier this year in a focused image edition of JACE. I briefly wanted to share something exciting from our collaboration with the Methodist group, where Steve Little, myself, and especially Eleonora Avenatti has done fantastic work traveling between Texas and Seattle and enjoying that, doing actually assessment on a larger number of patients to use 3D color as a means to assess baseline versus results after mitral clip in a perhaps more meaningful way, because we struggle in assessing mitral valve regurgitation after the clips have come in. Here's a quick illustration of how a functional MR case may look like, with the vena contracta area being cropped into. It's quite large, but in the long axis to the right upper, it will be underestimated, with the vena contracta width only being 0.5 centimeters as opposed to a vena contracta area of 1.3. Now, what we did in the study, we had more than 200 patients initially, but finally settled on 155 with complete pre- and post-3D color data sets, and then had a single observer go through the very painful and laborious assessment of vena contracta areas before and after each clip. And then looking at our results for the entire group of 155 patients, you see a significant reduction of the mean vena contracta area from 0.9 to 0.25 centimeters squared. And then when we did a ROC analysis, you see that we actually found a threshold. So as long as you get that vena contracta area reduced below 0.27 centimeters squared, you will be in a good space, is what at least was applicable in this data set. And to show you additional evidence, we looked at some functional endpoints, and we looked at these patients' New York Heart classification being more in the 1 to 2, as long as we've met that threshold. And they would come, fewer times back to the hospital or have less reporting on congestive heart failure. This is work that we are in the process of publishing. I want to shift gear and kind of go to this article, which also came out in April, where we actually used our opportunities to look at the mitral valve and ring work in native mitrals as well. And use echo to guide those procedures. I don't have time to go into detail. Suffice it to say that there's a number of aspects that we need to really thoroughly look at baseline, including the mitral valve leaflets, the annulus, the LVOT, and potential obstruction, as well as the approach. Now here's a patient, to make a case in point, who came with a previously placed annuloplasty ring. You see significant regurg on the left upper, although actually in 2D it looked even more impressive. We selected a 29 sapien valve as part of the mitral study for this particular patient. And here you see some baseline images in the quad view on the left, and then the significant MR on the right-hand side in 2D. Now, for this patient, we also can use multimodal imaging, including a multiplanar assessment. As you see here in the still frame, the right upper image will show you how we can actually explore the neo-LVOT and the LVOT on echo, and then come to a final result after the valve is placed, and actually measuring out an area for the neo-LVOT. Here, the moving images, again, biplane imaging allows to avoid tilting and an oblique approach to the mitral valve. On the right-hand side, you see the deployed mitral valve in-ring with the anterior leaflet actually still hanging out at the bottom. You see coming into the mitral inflow at times that can actually cause an additional area for narrowing, at least. Here are the two views with color and without color, a nice result and stable position. Now, taking that 3D data set further, you see on the right-hand side how we can slice it and then actually get an assessment of the neo-LVOT as you see it here measured out. The deep transgastric view then gives us laminar flow as long as there's no obstruction in LVOT, again an important final assessment. Now here's another case of a mitral valve repair. Again, complex history. I don't have time to go into much detail, but this was one of our first patients to actually be included into the Accucinch ventriculoplasty system trial that is ongoing. Here's just a snapshot of the anchoring device as it's coming out of the guide delivery system or catheter. The baseline assessment of MR in this functional patient who also had significant reduction of his LV function. Now, here's the procedure. As you see, a lot of gymnastics or yoga on the TE to assess all the different views in order to follow the procedure. And especially important on the right-hand side, you see a snapshot of the guide catheter coming through the aortic valve, hopefully not causing too much AI, and then being clear of all the papillary muscles. There you see the catheter actually coming through the aortic valve in the background, and then around the posterior aspect of the mitral valve, which is really the tricky part. And that's what I wanted to dwell on the left-hand side image. In this first patient, what happened, there were a number of papillary muscles that were very close to each other, and the catheter actually, the first wire and catheter came through two papillary muscles, and we had to stay clear. So it took quite some tweaking and redundant imaging in order to get clear of that papillary muscle. There's no fluoro that can help you that. You have to know what you're looking for and really work hard on these views. Here you see it in the long axis view on the right-hand side, and then again a biplane on the right, on the left-hand side as well, where we finally got a clear position of the catheter staying free of all the cords, chordal apparatus, and so forth. Now, for the last few minutes, I'm going to just use an effort to not forget the tricuspid valve. 3D color, again, along with 3D enface, showing a nice orientation. It is important to always know what you're looking at. So we're using biplane imaging as well as multiplanar TE, both 2D as well as 3D. Certainly, if you have a 3D view like the one on the right, you know that you're looking at the septal leaflet close to the aortic valve on top, the anterior leaflet, and then the posterior leaflet. That gives you a lot of confidence. Now, grading TR is not trivial unless it's trivial. If you look at severe and moderate, that's where it's more difficult. And we really work based on exclusion of certain criteria, and I highly recommend this guideline paper that came out in JACE in 2017. For a functional TR case, you may appreciate on the right upper image how the leaflets of the tricuspid valves are also pulled towards the apex of the right ventricle and then causing significant TR as seen at the bottom in 3D color. That's more functional type. Here's a congenital case of a very interesting patient that we considered for MitraClip, and eventually we shied away from treating her, and admittedly under anesthesia her TR wasn't as bad. But you see this ginormous tricuspid valve that imaged real well. You see the chordal apparatus at the bottom, just to share how various or how variable 3D imaging of the tricuspid valve may look like. If we take that in a multiplanar assessment, you see it on the left. You can assess the tricuspid annular area as well as the tricuspid regurg quite well. Here's the enface view with 3D color again, not looking as impressive, but if you put it in perspective, this valve was more than 5.5 centimeter in diameter, so already we're starting looking at a very different dimensionality. Lastly, a case for tricuspid regurg, a lady that clearly was not a candidate for an open heart surgery approach, got first treated for her mitral valve with one clip. The result is seen here. These are the enface and from ventricular views for the mitral valve. And then, interestingly, we looked at the pulmonary venous flow pattern that's very low in velocities. If we keep that in mind for later, here's the tricuspid regurg, obviously torrential, as we have now found a new grading adding above severe TR. The approach here with the guide delivery system for the MitraClip, as we pulled back from the transeptal position, we found that the patient dropped the sats significantly, most likely due to a change of its shunt, which is shown here. You see that the left to right shunt became really impressive and the patient desatted. So we had the advantage of using that as a technical marker or therapy marker as we went forward with our procedure. Here's the orientation within the tricuspid space or above the tricuspid valve in the SVC coming down to the tricuspid. Again, important always to communicate which leaflets are we looking at. Obviously, if you have a 3D like this, it's easier to be done that way. At times we can annotate if need be. We bring in the clip, again, looking for perpendicular approach to the leaflets, anterior and septal in this case. A first clip positioned here, an initial reduction. We added a second clip to bring down our degree of TR. You see here the engagement of the leaflets. And then finally, 2 clips in place, a significant reduction and normalization of hepatic venous flow pattern. And then of interest, the IASD had now rechanged his directionality, and we have much higher pulmonary venous flow. So in summary, 3 clips in 1 patient, both valves treated well, and I'd like to conclude that echocardiography is key to determine complex valve pathology suitability for the right percutaneous approach. 2D and 3D need to be challenged for invaluable input, and then finally the role of the interventional echo will only increase as we also add new